Okay, your next presentation will be by Dr. Aman for early readmission after bariatric surgery and Nsqip analysis from the Johns Hopkins University.
Good afternoon, everyone. My name is Mustafa Aman, and I'm from the Johns Hopkins School of Medicine. And this afternoon, I'm delighted to have the opportunity to present our work on early hospital readmission after bariatric surgery. We have no financial ties or conflicts of interest to report relevant to this study. So, as we all know, obesity has really become one of the leading healthcare challenges of the 21st century, both in the United States and around the world. Of course, obesity is associated with multiple comorbidities such as diabetes, hypertension, sleep apnea, coronary artery disease, even certain types of cancer. And as the prevalence of obesity rises, we're really starting to become more aware of the socioeconomic costs associated with obesity and all the complications from obesity in terms of decreased productivity, lost income, healthcare-associated costs, and disability-related costs. With the advent of laparoscopy and improved perioperative techniques, bariatric surgery has been increasing in popularity. And of course, we all know that it's far more effective than dietary, pharmacological, or behavioral interventions. The most recent data from the ASMBS cites a 15% rise in the number of bariatric procedures performed in the United States between 2011 and 2013. So for this study, we were interested in looking at hospital readmission. This has become an increasingly important outcome measure for a variety of reasons. It's one of the variables that's looked at by the Nsqip for accreditation of bariatric centers in the United States. There are also financial implications to centers with high readmission rates. Section 3025 of the Affordable Care Act is the Hospital Readmissions Reduction Program, which actually mandates for the Centers for Medicaid Services to decrease reimbursement to hospitals with high readmission rates. And so this information is being collected and also reported to the public in the near future. And there's really a limited amount of data in the literature on early hospital readmission after bariatric surgery. So the objectives of our study were as follows. Number one, we wanted to define clearly what was the incidence of early hospital readmission following the most commonly performed bariatric procedures, the gastric bypass, the sleeve gastrectomy, and the adjustable gastric band. We then wanted to explore that data further and try to identify underlying reasons for hospital readmission and see what we can do to help prevent readmissions wherever possible. We did use the ACS Nsqip database. And we performed a retrospective review over a period of 2 years, between 2011 to 2013. We chose that time frame because that's when we had not only ICD-9 coding about the number of patients who were readmitted, but also the underlying reasons for their readmission to the hospital after bariatric procedures. A definition of early hospital readmission is outlined there very clearly. It's at least one hospitalization within 30 days of the bariatric procedure, regardless of whether they were admitted to the same hospital or to any other hospitals. So here's some of our results. There were about 36,000 patients that were included in this study. The mean age of our patient population was about 44, and the mean BMI was 44.7. And we found that the overall early hospital readmission rate for all bariatric procedures listed previously was about just under 5%. Here we have a chart outlining the rates of readmission or reoperation by individual procedures. And for those of you in the back, the blue bars there are looking at the rates of readmission, and the purple ones show the rates of reoperation. And what we wanted to highlight here was that the gastric bypass, regardless of whether performed laparoscopically or open, had a higher rate of readmission as compared to the sleeve gastrectomy and the lap band, with the open gastric bypass having the highest rate at just under 8%, and the sleeve gastrectomy at about 3.7%. The rates of reoperation were fairly low across the board, with almost all of them falling just around 2% or less, although it was still a little bit higher in the gastric bypass group. We then wanted to explore that data a little bit further and try to analyze how far out from surgery the patients were being readmitted to the hospital. And so on the left hand there, you see the postoperative data. On the x-axis, you see the type of procedure listed. And what we can see here is that the gastric bypass and sleeve gastrectomy patients, again, regardless of laparoscopic or open, if they were to be readmitted, they all tend to be readmitted somewhere around the 2-week mark, between post-op day 13 to post-op day 15, whereas the lap band patients were being readmitted earlier around post-op day 8 or 9. Here we have a slide listing the reasons for hospital readmission in the first 30 days after bariatric surgery. And really, we just wanted to highlight that the top 3 causes are essentially GI-related symptoms: nausea, vomiting, abdominal pain, and dehydration. Other known complications of bariatric surgery, such as DVT, PE, infectious complications, internal hernia, bowel obstructions, were much lower on the list of reasons for readmission within the first 30 days. We then performed a multivariate logistic regression analysis looking at factors associated with early hospital readmission. And what we were able to find was that patients of African American or black race had a statistically higher odds ratio of readmission as compared to patients of white race. And this has been corroborated in other findings in the literature as well. We also found that patients with an elevated BMI had a higher odds ratio of readmission, and patients who had the open gastric bypass also had a higher odds ratio of readmission as compared to the ban. And what you can see here, interestingly, is that between 2012 to 2013, there was a decrease in the number of readmissions. In conclusion, our study has found that the overall early hospital readmission rate following the ban, sleeve gastrectomy, and bypass is about 4.7%, with the top 3 causes really being attributable to GI-related symptoms listed above: nausea, vomiting, abdominal pain, and dehydration. And so what we wanted to do was then identify which group of patients were at higher risk of readmission. And based on our findings from this study, we found that patients who had an open gastric bypass, patients who had a BMI greater than 50, patients of black race, and those who had prolonged operative time or a known pre-discharge complication had a higher odds ratio of readmission within the first 30 days after surgery as compared to other patients who had bariatric surgery. And so this is the group, the subset of patients whom we want to identify and pay closer attention to try to make sure that they are in good condition before discharge and have close follow-up after discharge to prevent readmission. And then finally there, I just wanted to mention a little bit about the DROP program, which was briefly discussed previously. And of course, this stands for decreasing readmission through opportunities provided. And this is based out of the study that's listed at the very bottom of the slide there, out of Stanford, where they were able to decrease their readmissions from 8% to 2.5% after a readmission bundle that included improved perioperative patient education, medication reconciliation, and close postoperative follow-up. We still think that there's future large-scale studies needed to identify additional patients at risk and to validate these protocols. Thank you for your time. I'll take any questions.
Questions?
Well, I want to ask you and panelists the question, probably indirectly just tells you how the data may not be accurate from bariatric Nsqip, because in my practice and speaking to other people, probably 1 out of 10 that gets readmitted gets surgery. As you said, most of them coming for dehydration, vague, non-specific abdominal pain, vomiting. In your slides, 1/3 of those readmitting end up in operating room, which means that a lot of so-called soft readmissions were probably missed.
I'm sorry, I want to make sure I understood your question. Was that
30% of people who are readmitted in your data end up having surgery during readmission?
I'm not sure that, perhaps, let me see if I can go back to this.
You want to go back to about 4 or 5 slides?
Can we bring up his slides again, please?
Yeah. I think the data there was looking at nationwide the overall readmission rate, and out of that proportion, how many of them had reoperation. And certainly the ones who had reoperation were far lower, about 2% or lower generally. But of course, we had limited data on that particular subset of patients as to why they had what was the underlying reason needed for reoperation, because it's a retrospective database analysis. Yeah.
Can you just update us on what some of those pre-discharge complications were that led to readmissions later? I don't think I clearly saw that.
Yeah. Unfortunately, we don't have specific information. It's just listed as an ICD-9 code in the database. And so it just says that they had, by the clinical reviewer, it's just documented as a pre-discharge complication, but we don't have information about what type of, what the underlying cause was. We did have a breakdown of whether or not the cause for readmission was related to their bariatric surgery or not. So for example, there were a small number of patients who were readmitted to the hospital within 30 days for some unrelated cause, such as getting a femur fracture, for example, was one of the patients who readmitted after a procedure, had a femur fracture and came back to the hospital. So that's clearly unrelated. And so what we did was we were able to find that about 84% of the readmissions amongst those bariatric patients within the first 30 days was deemed as related to the surgery by the clinical reviewers.
I think your study provides an excellent opportunity for everybody to at least pause and consider possible interventions that they can institute in their own program to try to decrease some of these rates of readmission. So my question is, based on this study, what are you guys going to do different?
I think we're going to take a closer look at our patients being discharged from the hospital and see if any of our patients fall into one of those high category risk groups, those with higher BMI, patients of African American or Black race, patients who have had a known pre-discharge complication or prolonged length of stay. And I really just kind of want to credit some of the findings reported from John Morton's study, where we looked at the readmission bundle. At Hopkins, we are one of the participating sites in the DROP program, and so what we've been doing now is really improved patient education prior to the surgery, making sure all our patients get their discharge medications before they even leave the hospital, making sure they have their medication reconciliation, making sure that they're given antiemetics as well as all their medications, and then very close postoperative follow-up, especially if they're deemed to be a high risk. And we have a bariatric nurse that calls them immediately upon discharge the day afterwards to check on them and make sure that that they're doing okay. So I think how this will translate to change in our practice is that we'll take a closer look at our patients who we think are more high risk based on our findings from the study and just have closer postoperative monitoring.
Yeah, I think that's great. I actually, in our system, we have 3 different hospitals that have an accredited bariatric program. And our readmission rates at 2 of the hospitals, a little bit less than what you found in this study, but fairly similar. And then one of the hospitals has like a 0% readmission rate when it comes to abdominal pain, nausea, vomiting, dehydration. And it turns out in their ER, they actually have like a short stay unit where a patient can be observed for 23 hours, get that rehydration and go home, so it doesn't get counted as a readmission.
Right.
Not all hospitals have that sort of a facility, but I think that maybe we should look to having facilities like that in a lot of our institutions, because I think that might also help decrease some of these numbers that could be avoided by having outpatient infusion centers and these types of short stay units. It's really interesting. Great paper. Thank you.
Thank you very much. Thank you.